So the first specimen is from a 69-year-old male. So he had a past history of the high-grade urothelial carcinoma presented as hematuria. So here we have his urine specimen. We see some drying artifact, and also the cell is concentrated at the periphery of the circle, so it's more easy to get these drying artifact and like a distortion of the cell from the like a spin. But again, just like a case that we saw yesterday, we do see increase the size of the nucleus, irregular nuclear contour. It is hyperchromatic, and yeah, we do see increased NC ratio as well. So this looks like high-grade urothelial carcinoma, but it is not very well preserved. You do see some like more atypical cells. Sometimes you can see some nucleolus as well, and also some like perhaps this is chororaceous, like nuclear debris over here. There's a larger segment with more preserved chromatin pattern. So this cluster is much well preserved. You do see hyperchromasia and increased NC ratio. So this is a high-grade urothelial carcinoma. So the next case, the patient had the past history of esophageal squamous cell carcinoma. This is the pleural effusion specimen. So it is very uncommon that we will see squamous cell carcinoma in the body fluid, but this is one of the examples. So for this case, you do see on low power, you already see the cells are really hyperchromatic. You see like very dark staining nucleus, and with a little bit dense of cytoplasm. There are some cell-in-cell pattern. However, if the SCC develop more like a high-grade feature polydifferentiation, sometimes it's very difficult to differentiate it from the polydifferentiated adenocarcinoma, because you can also see prominent nucleolus, sometimes more vacuolated cytoplasm, just like these here. Looks a little bit like mucin. For the architectural pattern, it is more common you will see squamous cell carcinoma with a flattened nucleus and a wrapping around the cluster. So if we take a look of the cell block preparation, because HE stain usually highlights the chromatin, the keratin better. So here we see this looks like a squamous cell carcinoma. So this is compatible with metastatic squamous cell carcinoma from the patient's non-history of esophageal SCC. So we had a couple pancreas US guided biopsy. So this is the first one. On low power, the background is highly necrotic. So you see mostly necrotic debris. Additionally, you start to see some more preserved cell, but with really high NC ratio. And here you do see the cells forming a toe columnar pattern, and with vesicular chromatin and prominent nucleoli. Here you see prominent nucleoli, and this is arranging a glandular pattern, so this is a high-grade adenocarcinoma. So the second case is also from the pancreas. For this case, we do see some normal intestine elements. So this is the normal mucosa. But we also see similar feature with pleomorphic tumor cells arranged in an irregular glandular pattern. The nuclear polymorphism is lower grade compared to the prior case, but you still can appreciate that the arrangement is very disorganized, and you see these abrupt, like a mucin production. So this is also an adenocarcinoma. We do not see striking necrosis, but we still can see a little bit of necrosis in the background. So overall, these cases lower grade, but still it is definite for positive adenocarcinoma. The next case is relatively not so common in our practice. Also from the pancreas, but what is different is that on low power you see a lot of mucin material. This is a liquid-based preparation. So if you see a little bit of mucin, which means there are a lot of mucin. So we do see a lot of mucin in the background, which suggesting that it is a mucin producing tumor. So we start to see some mucinous epithelial cells. Some shows a more like a low-grade, well-differentiated pattern. So these combinations suggesting that it could be IPMN, intraductal papillary mucinous neoplasm. For the IPMN, we want to check if there is any high-grade dysplasia. So in this case, we do find some of the glandular show high-grade dysplasia. So we see high-grade glandular cells, and we see some low-grade cells with mucinous production as well as mucin. So I think this is compatible with an adenocarcinoma arising from intraductal papillary mucinous neoplasm. Sometimes it's a little bit difficult to distinguish if it's still in situ, still within the low-grade dysplasia, or it is invasive already. So when this is the situation, we don't have the architectural pattern, we cannot see the invasion in cytology, we will check the CD99. The CD99, CA199, CA199 is slightly elevated. It's like a 2 or 3 times above the upper limit, around 90. So it is indeed increased. I think the case already developed invasion. We do see striking high-grade dysplasia for this case. So Dr. Gao has a couple of stents on the concurrent biopsy. So this is, we will wait him to have the final diagnosis, but I think we can call this adenocarcinoma. So the next specimen is coming from a bone aspiration. The patient had past history of colon cancer. So we see a few tiny structure. So this has a glandular arrangement, and with hyperchromasia and overlapping of the nucleus, we do see some stratification. So this looks like indeed intestinal type glandular cell with a TPR. In addition, we also see these multinucleated giant cells. So this is osteoclast giant cells. Right next to it, we see a typical gland. So this is metastatic adenocarcinoma. The morphology is compatible with colorectal origin. The next specimen is coming from a patient with a past history of GIST, gastrointestinal stromal tumor. During the survey, during the follow-up, the patient was discovered to have a focal lesion at the T-spine. So the clinician wants to rule out if it is a metastatic lesion. First of all, it is very uncommon to see a GIST metastasize to a distal location, particularly the patient is already under the TKI treatment. So here we didn't see spindle cell. We see very prominent and uniform monotonous proliferation of these plasmacytoid cells. The patient is 78-year-old female, so this is compatible with plasma cell myeloma. It's a multiple myeloma, presenting as a single focal lesion in the spine. So next, let's take a look at some pap smear. So this is coming from a 44-year-old female. So you see on low power, the background is very clean. We have a lot of superficial cells, so compatible with the younger age of this patient. And so in this smear, usually we were looking for either a precursor lesion or microorganism. But because of very clean background, probably no microorganism. So we see some endocervical cells. So this is the endocervical area. You start to see some mucin. And let's take a look of the endocervical cell. This is the normal endocervical cell looks like. Should be honeycombing. And the cytoplasm have some vacuole, and with a very light staining, can be a light like grayish, bluish, and a little bit oranginophilic. This is a honeycombing arrangement, flattened sheet. So this is the normal endocervical cell. And we start to see some superficial cell with coelocytic change. The cell has increased size of the nucleus. It is not very hyperchromatic, but developed a coelocytic like a halo. There is a smaller cell with binucleation. So we will see if we can find some more, because that was not like very typical for low CO cells. Here we see some more. So again, intermediate cell in large nucleus and with the coelocytic chain. So in this specimen, we do see quite some low CO cells, so we call these low CO. So again, we see a binucleation cells and some coelocytic chain. So this is a low CO case. So our screener also do a very good job by identifying some interesting cells. So on low power, these looks quite suspicious because this is hyperchromatic. The nucleus shows some polymorphism, right? There are some bigger cells, smaller cell. The arrangement is very like not well organized comparing to the endocervical cell that we see. And because it's a little bit hyperchromatic and the NC ratio is slightly increased, so you are thinking about, this is a hyperchromatic crowded cube, and is it a squamous cell? Is it a glandular cell? So you need to check. And is it like a high CO? Should we call it ascus high? But then you start to see there are some ciliation over here. There is a terminal bar over here. So this is tubal metaplasia. So tubal metaplasia is one of the mimicker for high CO. Okay, so sometimes the nucleus can indeed have a striking polymorphism, increased answer ratio, hyperchromatia. Everything looks like high CO. But you start to take a look that there is a terminal bar and there are some ciliation over here. So in the old time, I mean, before last year, I never see these in the conventional smear, but last year we already see 3. So I mean, so when we start to look for that, it is there. Okay, so here again, this is more like a benign looking endocervical cell with a little bit overlapping of the nucleus. There is a vague terminal bar here and some ciliation. And I think there's one more. Again, so you see a terminal bar and cilia. And this is more like a well organized. It's all seated in the basal, like a location. Yeah, but the reason that it is a mimicker is because sometimes you will see these hyperchromatic cluster. So be aware, do not overcode these as high CO, ascus high. So we just call this negative. So this is low CO and with tubal metaplasia. So I want to talk about the case that we see about almost 3 months ago. This is also a pap smear. So this is coming from a relatively elder female. I remember 67-year-old female with only watery discharge. So she came to our outpatient clinic by pelvic examination. There's no significant findings. So she only received 1 pap smear, and that's it. So in this pap smear, this is very we see this is low cellularity. We didn't see a lot of cells. So we do have some intermediate cell with like a metaplastic feature. So these look like coming from an elder patient, like atrophy. Yeah, so this is atrophy and scan cellularity. But at the periphery of the slides, we see some mucin. But when we go to higher power, it looks a little bit strange. So the mucin, like in the cervical cell that we just see, is very common. But this one looks a little bit strange because you start to see these very unusual, like a pycnotic degenerative cells. So this is a degenerative mucocyte or a mucin phage with degeneration. So when you see something like this, you need to pay attention because this could be a sign for endocervical like a glandular lesion. So additionally, we find only 1 cluster of a typical cell. So this cell show like a striking oranginophilic cytoplasm with a very tight small cluster. And when you see some gland like these, if you put this into the ascites, you will think about this is a pancreatobiliary adenocarcinoma. So the color of the mucin, the pattern of the glandular cell is not normal. It's not like what we just see in the normal endocervical cell. This is more brightly oranginophilic, suggesting that it might develop some gastric-type metaplasia. So additionally, we also see another area with these like a mucinous background. So on low power, you see mucin. On high power, again, these mucophagy develop like more degenerative, like choriorative pattern. So a little bit looks like so-called ileocondyl urine. So for this case, we think that the patient might have some is likely have an endocervical glandular region, and which produce like gastric type mucin, and develop some chorioresis, maybe necrosis. So for this case, we call it a typical glandular cell favor neoplasm. So the patient, after the diagnosis of the pap smear, the clinician do a colposcopy biopsy to check if there is endocervical lesion, but this is negative. But we also didn't see any endocervical cell. The patient also had a DNC, a ECC. Here we see some endocervical glands, which looks not very abnormal. It just like mucinous. It doesn't look like gastric type mucin. This looks more like typical endocervical cell, not very abnormal. So just a very like a subtle finding. So there's no significant finding, and I think the patient do a cone. I'm not so sure if I have cone here. But anyway, in the end, the patient do I think the cone is also negative, but there is a DNC seems to be a little bit atypical, and so because the patient already postmenopause, so the clinician decided to do a total hysterectomy. So this is something that we are looking for. This is more relatively like benign endocervical cells, but this is not normal endocervical cell. It looks like it's developed some like a gastric type metaplasia, and with a lobular type of pattern. So this is called lobular. I always forgot the name. Lobular glandular epithelial hyperplasia. Something just suggests that it is a glandular lesion with a gastric metaplastic pattern, and you start to develop this dilated cyst going down. Okay, so the pattern start to be a little bit abnormal, but this type of gastric type adenocarcinoma is notorious for very, very bland-looking cytology. So we used to call these either adenoma malignant or minimal deviation adenocarcinoma. So this is, I would say, this is probably the most challenging entity that we will see in the pap smear. And even in the large excision specimen, it is very difficult to diagnose. So you start to see some like a mucinous gland with gastric type mucin, and going deeper to the tissue, it's almost exceeding half of the thickness of the endocervix. It's difficult to decide if it's adenocarcinoma. However, the patient this is the endometrium. So it developed like a spreading along with the endometrium cavity. So the endometrium, you won't see this mucinous type of gland, but it goes up to the endometrial cavity, involve the endometrium gland, and then develop more like obvious adenocarcinoma, which is in This is normal endometrium. And which slide? This one. Yeah. So it developed like unequivocal adenocarcinoma in the endometrium cavity. So because this is coming from the endocervix, it is hormone negative, ER negative. And because this is gastric type, this is also HPV unrelated. But it can spread all along with the endometrium cavity all the way to the, so this is already in the fundus, but it developed this invasive adenocarcinoma, more obvious here. So overall, after a discussion with the other gynecologic expert, so we all agree that this is adenoma malignant. This is a cervical gastric adenocarcinoma and involved the endometrium cavity. And it all coming from the patient only show watery discharge, and she received one smear, and we see something like this, and we identifying, and also the clinician is very persistent because we give the diagnosis, we give the atypical glandular cell favor neoplasm, and we denote that we consider this is a gastric type like mucinous lesion. And so he was really persistent. Even though the colposcopy is negative, he still keep doing the cone. And after the cone, he do the ATH and identify the lesion. So it all coming from just this. So this is a very important finding. It is not so common. In this case, I would just say our screener do a very good job by highlighting it, because this component is very, very scant. This is a very scant cellularity specimen, and the glandular components is even more scant. So our screener do a really good job on identify these. And again, just like what I say, this probably is the most challenging entity in the pap smear that you can identify. So we need to just check the case again. And this should be put it in the file for the education. Okay, so that is the case for today. Thank you.